Welcome to ATCM. 72-year-old female was brought to the ER with complaints of itching and swelling over lips since half an hour back. Initial 10-second assessment, patient was conscious and oriented and obeyed commands. Primary survey, airway, patient with no pooling of secretion or abnormal airway sounds. She was able to talk normal and able to complete full sentence. C-spine appear normal.
1 minute. What was the 10-second assessment? Can you please repeat?
Patient was conscious and oriented and obeyed commands.
No, 10-second assessment. You started the case, no?
Yes, sir. A 72-year-old female was brought to a year with complaints of itching and swelling over lips half an hour back.
Okay, fine.
Airway, patient with no pooling of secretion, abnormal airway sounds. She was able to talk normal and able to complete full sentence. C-spine appear normal. Breathing, on auscultation, chest clear with bilateral equal air entry, symmetrical and adequate chest movement. She had respiratory rate of 18 per minute and oxygen saturation of 99 in room air. Circulation.
No, it's okay. This is our standard format, right? ABCD. But in this ABCD, when you say there is no gurgling sounds, there is no foreign body, and there is no airway obstruction and all. When you say that, it should be specific to that patient. It shouldn't be just like we are saying it for the sake of saying it. What is this patient's complaint? Patient was brought to you with complaints of swelling and itching over the face, lips and body. This is the presenting complaint, right?
Over lips only.
Over lips. So if such a patient is coming, what is the first thing that comes to your mind? Patient presents to you with swelling over lips, itching over the lips, presenting to you. What is the first thing that comes to your mind?
Is there any laryngoedema?
Laryngeal edema will come. That is under features. No. So if a patient comes to you saying that I am having itching over the hands and face and body, or in the face I am having itching and swelling, what is the first thing that comes to your mind? What is the disease that comes in your mind? Allergic reaction, right? Speak up now. Allergic reaction, right? So if you are suspecting allergic reaction, the airway should have features of allergic reaction. You should mention those features are there or not. It's not patient doesn't have no foreign body or gurgling. We are not expecting this patient to have gurgling and foreign body there. Are we?
Yes.
No. We are expecting anaphylaxis or allergic reaction. What are we expecting? We are expecting airway compromise in the form of edema. So what you have to say is there swelling of lips? Is there swelling of tongue? Is there swelling of uvula? Is the patient having a obstructed airway due to edema? This is the main thing you have to say in airway. Okay, and of course you have to mention whether stridor is there, because this is specific to this patient. Okay, so if an RTA patient comes with low sensorium, we can say there is no gurgling, there is no foreign body, because we expect that patient to be fallen down having a head injury and having an absent gag reflex, isn't it? But this is not the condition. This is a fully conscious oriented patient who is talking to you. Of course the patient will not have any foreign bodies or any secretions there. If they are having a secretion, they will either swallow it or they will spit it out, isn't it? So when we say ABCDs, it shouldn't be just like I'll just say ABCD. It should be specific. The history is very specific. Patient presents to you with swelling, itching over face. First thing everyone will think is allergic reaction. There is no doubt. But when you present the case, when you present it, it should be like, I suspect allergy, I looked for allergic causes that can cause airway obstruction, and I ruled it out. It should always be like that. Okay.
Circulation, good peripheral pulses, pulse rate of 98 per minute and blood pressure of 130/60 mm mercury. Disability, GCS was 15/15, pupil 2.5 mm bilateral reactive. Exposure temperature 36.3 degrees Celsius. Adjacent to primary survey, ABG.
Here. Circulation, all those are fine, disability and all. But when you come to exposure, now you have what are you suspecting? You are suspecting allergic reaction. Then in exposure, we have to look for signs of allergic reaction. Okay, because anaphylaxis is an emergency condition. Even allergic reactions, moderate to severe allergic reactions or mild allergic reaction, is an emergency condition. So those features should be mentioned in exposure. So the main exposure is not history. You are not asking the patient, are you exposed to drug or food? That we can come in ample history or sample history that you take. But here, what you are looking for is exposure to bites, stings. So you can ask the patient, did you have a bee sting? Did you have a wasp sting? Did you have any bites from any insects? You can look for any markings over that. Because if it is bee sting, if it is especially honey bee sting, the sting will be embedded in the skin, and unless you take it out, there will be ongoing anaphylaxis reactions or allergic reactions. So it's very important in exposure to look for what caused the event.
Insect bites.
Okay. So, and second thing for everyone, when we take emergency cases now, it's not fixed like you have to only go through A, B, C, D, E, F. It's not like that. A, B, C, D, we say it because those are the things that threaten the life. But there is no written thing that at that time you can't speak to a patient. This ABCD is made in such a way that if a patient who can't speak to you or who is unable or who is unresponsive comes to you, you can manage even if you don't have a history or you can't get details. This is the whole idea of having a primary survey, secondary survey, ABCD getting priority. That is, life-threatening conditions will be ruled out even if we don't have a history. Got it? But this is a patient who is speaking, isn't it?
Yes.
You can talk. In exposure, you can say the patient gives exposure to insect bite, sting bite. Because if you are dealing with anaphylaxis, I'm not saying this is, but if you are dealing with anaphylaxis, all you get is minutes. You either treat the patient in those minutes or patient worsens in those minutes. And anaphylaxis, a full-blown anaphylaxis, is a nightmare to manage. Okay, so the idea should be instant recognition, instant treatment. For that, you shouldn't follow a linear approach. You can follow a horizontal approach. You can do multiple things together. So, exposure part, in these cases, exposure part, you can say no history of insect bite, no history of wasp sting, honey bee sting, all those things. Okay, fine. Adjuvants.
Adjuvants. ABG pH was 7.4 and PCO2 is 35 and PO2 is 43 and HCO3 is 21, SO2 is 74. ECG, normal sinus rhythm at 78 beats per minute with no significant ST or T changes. Secondary survey, 72-year-old female came to emergency room with complaints of itching over body and swelling over lip half an hour back. Hence, she came to our hospital for further management and evaluation. No history of stridor and changes in voice, breathlessness, vomiting or chest pain, alerted behavior. Allergy history, no significant allergy history to any drugs or dust. Past and medical history, surgical history, known case of hypertension and diabetes mellitus, and she is on losartan 50 mg BD and metformin 500 mg TAD. And no history of tuberculosis or bronchial asthma, thyroid disorder. There is no significant past history relevant to her present complaints. General examination. On examination, patient was conscious and oriented, averagely built and averagely nourished. No pallor, itrus, cyanosis, clubbing, lymphadenopathy, Pulse rate was 95 per minute and BP was 120/60 millimeter mercury. Respiratory rate was 18 per minute and oxygen saturation was 99% in room air. Local examination, swelling, redness over both the lips. Systemic examination, respiratory system, normal vesicular breath sound, and cardiovascular system S1, S2 heard, and no murmur, no added sound. Gastrointestinal system, per abdomen was soft and no mass palpable. Central nervous system, no focal neurological defect or no signs of meningeal irritation. And lab investigation, hemoglobin was 10.4 and platelet was 321 and DC is 6.8, neutrophil 46, lymphocyte was 24 and eosinophil is 0.16. And diagnosis, anaphylaxis secondary to insect bite causing angioedema.
Now let's discuss. So, first and foremost, what is the difference between allergic reaction and anaphylaxis?
Anaphylaxis is like any dermatological changes along with A, B, C compromise.
You say like that, you can make up a definition.
After any exposure after an exposure of any allergen, if there are any dermatological changes along with the itching, swelling, this kind of thing, plus airway compromise or the breathing compromise, circulation.
Yeah, but fine. Basically, that's it. But you need to be specific about this. See, it's not compromise as such because there are comorbid conditions. See, anaphylaxis is a rapid systemic inflammatory response triggered by a allergic or triggered by an allergen or a compound that can cause acute mast cell degranulation. Now, the mast cell degranulation is what we see as the symptoms. Okay, now what are the symptoms? Okay, so let's start from top. The first and foremost symptoms, the most number of patients or the most commonest symptoms are urticarial symptoms. You get dermatological and mucosal symptoms. Okay, so dermatological symptoms are what? Itching, redness, basically hives, right? Hives. So you get itching, redness, swelling, and what are the mucosal symptoms?
Swelling of
swelling of lips, swelling of tongue, swelling of ula, swelling of conjunctiva, redness of conjunctiva, immense watering, sweating and nasal secretions. These are mucosal symptoms. These are the most commonest. More than 90% patients will have this. What is the other components that can present? Now, this component, what we said this is present in allergic reactions and in anaphylaxis. So, we can't use this as a differentiating factor between anaphylaxis and allergic component. Now, anaphylaxis has systemic effects. Allergy usually doesn't have systemic effects. So, anaphylaxis being systemic will involve multi-organs. So, it involves heart. So, when it involves heart and blood vessels, what happens? Patient develops?
Hypertension.
So, hypotension features you can look for. What are the features of hypotension? Cold extremities. Usually in anaphylaxis you will not get, you will get warm because there is inflammation happening. But
feeble
tachycardia, feeble pulse, tachycardia, acute altered sensorium. Okay, we are not talking about patient who is altered sensorium for long. After the incident, sudden altered behavior, altered sensorium or loss of consciousness, pre-syncope, syncope because hypotension induced. And acute hypotension can cause incontinence, bowel bladder incontinence. These hypotensive features can happen. What else can happen? What other system it can affect? our respiratory system. If it affects respiratory system, what are the features?
Wheezing.
You will have wheezing. So bronchospasm, you will have bronchospasm. Wheezing you will develop. Then you can have
Stridor.
larynx. If it is affected, you can develop laryngeal edema. And then what other system it can affect?
Shock.
GIT. You can have abdominal pain, cramping abdominal pain with the loose stools, okay, because of increased peristalsis, okay. And locally, mucosa, we have already told about mucosa, okay. So these are the features that we have. Now, any of these systemic effect has to be there to say patient is having anaphylaxis, okay. So, dermatology and mucosal features is not adequate to say patient has anaphylaxis. It should be having systemic effects. So, does this patient have systemic effects?
No.
So, this is it anaphylaxis?
No.
No, this is a allergic reaction. Okay. So, we know what are the features. Now, there is a criteria to say anaphylaxis. Now, first and foremost thing you have to understand, anaphylaxis is a clinical diagnosis. We don't do investigations. We don't wait for any test to diagnose a patient to have anaphylaxis, because it has to be instant and treatment has to be given within minutes. So, it's a clinical judgment. Now, as Naveen told, is basically ABC compromises that we look for. Even then, there is a diagnostic criteria. So, there is a diagnostic criteria by FAN criteria. FAN criteria has 3 different scenarios. But basically what it means that a patient should have either a known case of allergic history, that means a patient should know this thing is allergic to me. Patient gives a history that I am allergic to peanuts, I am allergic to seashells or shellfish or something like that. Or patient doesn't have any history of allergy. So, if a patient doesn't have a history of allergy, the criteria is basically acute onset, that is within minutes to hours onset of dermatological and mucosal features after the exposure of the supposedly allergen associated with either respiratory complaints, that is bronchospasm, wheeze, or increase in end respiratory pressure, or hypotension with features of reflex tachycardia, or GI symptoms. Okay, either one of these is there, you can say patient is having anaphylaxis reaction. Or else a patient who gives a history that I am allergic to a particular allergen and I just received a exposure to that allergic reaction, and if that patient has hypotension, you can say this patient is having anaphylaxis. So, there are 2 criteria like this. FAN criteria is there, and there is a World Allergic Organization WHO criteria is there. WHO criteria is much more easier. WHO criteria is what I told right now. It has only 2 things: either a pre-exposed patient who knows it's a pre-exposure, history is there and comes with the history of exposure with hypotension, you take it as anaphylaxis. Another one, without exposure, you need to look for features of anaphylaxis, systemic features of anaphylaxis. Now, even though we say criteria is like this, what we have to use is a bit of common sense. It shouldn't be like a patient comes to you with like shellfish allergy. I ate prawns now. I am allergic to prawns. I ate prawns now. Now I am having a lot of itching in my hands and mouth. But there is no hypotension. You shouldn't wait for hypotension to develop to say it is anaphylaxis. Okay, so that's the thing. The whole thing is, even though there is a criteria and everything, the administration of epinephrine, which is a treatment, adrenaline, which is a treatment, should not be delayed waiting for symptoms. So, patient gives clear-cut history. I have history. I have previously had anaphylaxis to this. Now I have exposure. You should not wait for other symptoms to develop. You should give adrenaline as soon as possible, especially if the patient gives previous history of anaphylaxis present. If previously not having anaphylaxis, we can withhold adrenaline and see whether patient improves. Now, will an anaphylaxis patient improve by himself?
Yes. Spontaneously.
Usually, spontaneously, anaphylaxis can improve or even get treated off. That is because there is endogenous production of adrenaline in our body. Adrenaline and angiotensin. Adrenaline and angiotensin both will treat anaphylaxis. It's something our body itself makes. So patient may present to you with a history of worsening, but right now feeling better. That shouldn't be taken as patient is not having anaphylaxis. It can be anaphylaxis which is now resolving due to endogenous production of adrenaline and angiotensin. Similarly, if we say endogenous production of adrenaline and angiotensin will deplete the anaphylactic reaction, patients who are on angiotensin receptor blockers and beta blockers will have worsened features of anaphylaxis. Got it? So, any patient who has comorbidities like asthma will have exacerbated features of anaphylaxis because asthma will also get triggered. So, their breathing difficulty, wheezing, everything will be much more worsened. Similarly, if a patient is having cardiovascular diseases, that alone will be a high mortality producing factor. The mortality due to anaphylaxis is not that common, but if it is anaphylaxis mortality is there, it will be increased if a patient is having coronary artery disease. Because of high stress that happens, patient can go into ACS and MI. Similarly, these things we told, there are certain drugs that produce anaphylaxis. What are the drugs that can produce anaphylaxis?
Antibiotics.
Antibiotics. One of the most common antibiotics that is allergic to human body is penicillin. It need not produce anaphylaxis, it can produce allergen. Anything that produces allergic reaction can produce anaphylaxis, but all may not produce anaphylaxis as such. Can some drugs that can cause mast cell degranulation, is there any drugs that can cause mast cell degranulation as such? Vancomycin. Vancomycin can cause local or systemic mast cell degranulation called as Redman syndrome, flushing syndrome. Vancomycin flushing syndrome. When you give IV vancomycin, patient will develop sudden redness, itching over the IV axis and develop hypotension. So, vancomycin can produce like that. Any other drug that can produce mast cell degranulation, itching over the area? Opioids, especially morphine, meperidine, codeine, all these things. So, codeine patients on cough syrup and all, if they take, they develop itching over the throat, itching over the tongue and all. So, codeine, meperidine, morphine can produce local. But usually these things are self-containing because this is not like a Ig mediated reaction. Anaphylaxis is basically Ig mediated reaction in human bodies. There is non-immunological and immunological. If it is immunological, it's usually Ig mediated. Now, we told the symptoms, we told the criteria, drugs, some of the drugs that produce this. How do you treat this? What are the treatment modalities you have?
Adrenaline.
Yes. So, you have adrenaline as the life-saving drug. So, only life-saving drug for anaphylaxis is adrenaline. What are the other drugs you can give?
Antihistamines, corticosteroids.
So, antihistamine and corticosteroids. Antihistamine and corticosteroids is given for what?
Allergic reaction.
For symptomatic management. It's not life saving measures, it's symptomatic management. Basically for urticarial and dermatology mucosal features is what we give antihistamines, and to control further inflammation is what we give steroids. It doesn't have a emergency action. Emergency action is only for adrenaline. That should be clearly kept in mind. Is there any contraindication for adrenaline in anaphylaxis? There is no contraindication for adrenaline in anaphylaxis. That is the first thing we have to understand. Okay. Now, anaphylaxis treatment. How will you Give adrenaline.
0.3 to 0.5 ml diluted in 1:1000 solution, and it will be given as IM or subcutaneous can be
It's always given
IM.
only two ways, IM or IV. There is no subcutaneous because you are having inflammatory reaction. Patient can develop hypotension. So if patient is in hypotension, the peripheral vasculature will be cut off. So if you give subcutaneous, it will take a huge amount of time for them to absorb the medicine. So there is no point in giving subcutaneous. It should be either IM or IV.
IV.
Initial treatment of anaphylaxis is 0.3 to 0.5 mg adrenaline 1:1000 dilution given as IM. Okay, where are the IM sites you can give?
And anterior aspect of thigh.
Anterior aspect of the thigh. Yeah. For children, anterior aspect of thigh you can give. For adults, deltoid you can give. Okay. So if you give 0.3 to 0.5 mg IM, you are given once. Patient is not improving. What will you do?
Nebulization.
It's symptomatic. Will you repeat adrenaline or not?
Yes, repeat.
For how long? How much?
2 to 3 minutes.
For after 5 to 15 minutes, after every 5 to 15 minutes, you can repeat adrenaline, same dose, IM. Up to 3 doses you can give. And at the end of 3 doses, patient is not improving, then you can consider IV.
Infusion.
IV or infusion. There is bolus. There is slow bolus, IV bolus, and there is continuous adrenaline infusion. If you fail 0.3 to 0.5 IM given, it failed, and you want to give bolus dose. How much of bolus dose will you give? Adrenaline IV.
0.1.
0.5 mg.
0.5 mg to 1 mg. 0.5 mg to 1 mg dilution
1:10,000.
1:10,000 dilution given over 10 to 15 minutes. Very slow IV, because we are giving diluted but only 1:10th part diluted adrenaline IV directly. It can cause significant cardiac stress. So IV infusion should be given very slowly, not bolus. Now, what is much more safer is IV infusion. Rather than IV bolus, you can give IV infusion. If you start IV infusion, what is the dose?
0.0 microgram. Approximately
Infusion
60
will
kg
start.
per ml per hour, or we can give it as 0.0 microgram per kilogram.
Yes. Our normal adrenaline infusion for shock is what we are going to give. 0.1 microgram per kg per minute infusion we are going to give. Okay, so adrenaline infusion or IV we can give. Adrenaline is taken care of. Now, other systemic or symptomatic management is there. What else can you give? Antihistamines you can give, right? What are the antihistamines you can give?
Cetirizine.
Cetirizine, tabcetirizine, but tabcetirizine takes its own time to act, right? Patient is having acute symptoms now. It's better to give something IV. So what IV drugs can you give? Do we have IV cetirizine here? We don't have IV cetirizine, right? India doesn't have IV cetirizines. Yeah. What we have IV antihistamine? Diphenhydramine we have. Injection Avila, diphenhydramine we have. What is the dose you will give? 25 to 50 mg you can give diphenhydramine. Okay. That is, diphenhydramine is what histamine blocker?
H1.
H1 blocker. So there is something known as H2 blocker. So you have 3 types of histamine blockers. 3 types of histamine receptors. H1, H2, H3. H3 usually we don't block because it's inside the brain, it's protected by blood-brain barrier. But H1, H2 is there. H1 diphenhydramine can be given. H2 ranitidine we can give. IV ranitidine we can give and control. So this will give symptomatic relief for the patient. Now we have to prevent further worsening of the inflammation. For that we will give steroids. What is the most commonly used steroid?
Hydrocortisone.
Hydrocortisone. How much will you give?
100 mg.
No, we give
100 to 200.
we give 3 to 4 mg per 2 to 4 mg per kg. We give hydrocortisone, or else you can give methylprednisolone. Methylprednisolone you give 2 mg per kg. 2 mg per kg you can give methylprednisolone. Whatever is available, you can give it that. So, hydrocortisone, antihistamines, adrenaline. Patient is having wheezing. What can you give?
Nebulization.
Yes, you can give salbutamol nebulizations, short-acting salbutamol with adrenergic action nebulizations you can give for bronchospasm alone. Okay, so this is the management of anaphylaxis. Now, coming to anaphylaxis, if you think anaphylaxis is there, what is the first thing will you do? For example, this patient presented to you with itching and swelling over the face and lips and all. You checked, lips is swollen, tongue is swollen, patient is having difficulty in making sounds. What will you do?
Protect the airway.
No, you have to
If you
intubate the
want to
patient
intubate the patient.
as soon as possible. Airway protection should be done at that moment itself. So when you do airway protection, what is the most life-threatening condition you will expect?
Edematous vocal cord.
Edematous vocal cord causing obstruction. Cannot intubate state. What will you do?
Needle cricothyroid.
Cricothyroidotomy should be ready for these kind of patients. So ideally, if this patient comes to ER, airway management will take priority, and if airway management, you should be ready for a failed airway algorithm. Failed airway algorithm, usually we say 2 times by a experienced person, 3 times by a non-experienced person, 2 times by experienced person. That should not be done here. Anaphylaxis airway should be managed as soon as possible. So, an experienced person should try to intubate the patient. Okay, so intubate, ready for cricothyroidotomy, then give adrenaline. Can be given simultaneously, but airway should be taken care of. That you should not wait for it. Similarly, this patient comes, any allergic patient or anaphylaxis patient comes to ER, they should have 2 large bore IVHs, because any allergic reaction can worsen to a anaphylaxis. So, before they develop hypotension and all, if you put 2 IVHs, we will have adequate large bore IVHs, we will have adequate IVHs to give the multiple medications and adrenaline. That's the important part. Fine. Now, patient presents to your department saying that I had prawns and crabs yesterday night at 7 p.m. Patient is now presenting to you at morning 10 a.m. saying that I am having some difficulty, I am having itching over my back of the throat, and I am having abdominal pain and all. Will you suspect anaphylaxis?
Yes.
Delayed reaction.
Will you suspect? Yes. So, what are the types of anaphylaxis present? You have delayed anaphylaxis, which usually happens in hours. Usually it can happen up to 48 hours, but very, very rare. Usually it is, as we told in the definition, it's a rapid onset. So this is not a rapid onset, but patient can present with a prolonged delayed anaphylaxis. Then what you have? Then you have prolonged anaphylaxis. That is, even if the patient presents to you within minutes, you treat the patient doesn't improve. Even if you give adrenaline, antihistamine, steroids, patient remains symptomatic, and remains symptomatic for 24 to 48 hours is known as protracted anaphylaxis. That is, it is continuing to be in anaphylaxis for no apparent reason. We are not understanding why it is, but patient is in anaphylaxis. So, delayed is there, protracted is there. Then there are 2 types. One is acute onset, that we see every time patient that gets a exposure, soon after that patient develops anaphylaxis, and you treat the anaphylaxis stops. Then there is another criteria in which patient gets the exposure, comes to you, you treat, patient improves, but after 8 to 10 hours later, patient again develops another episode of anaphylaxis without any additional exposure. Okay. I don't remember the name for it, but there's like linear and bilinear or something like that. That name I'm not getting, but there's something like this. So patient can present with a repeat anaphylaxis exposure, well, anaphylaxis like symptoms without further exposure. Usually it is due to persistent muscle degranulation happening, and most probably those patients might not have got a steroid injection. You give steroid to prevent these kind of further reactions. Okay. If this was a child, how will you treat?
Same with the adrenaline points.
Same, drugs, everything is same. Dosage just. So you say hypotension in a child. What is the cutoff for hypotension? Up to 1 year, less than 70. Up to 1 year, less than 70 systolic is hypotension. 1 year to 10, 11, 12 years, it is 70 plus age into 2. 70 plus age into 2. 70 plus age into 2. Up to 10, 12 years. From 11 to 18 years, it is less than 90. Now, then adult, this thing will come. So that is cutoff for hypotension. What is the dose of adrenaline that you give? 0.01 microgram per kg is what you give. That is the other difference. So adrenaline becomes weight based. In adults we are giving fixed dose. In children it will become weight based. 0.01 microgram per kg. Then what about methylprednisolone, steroids?
Hydrocortisone can be given 25 mg in less than 6 months. And 6 to 12 years, 50 mg, and 12 to adult we can give 100 to 200 mg.
Basically 1 to 1.5 mg per kg hydrocortisone. Methylpred is same 1 to 2 mg per kg is what we give for pediatrics. What about this thing, diphenhydramine? 1 mg per kg. Diphenhydramine is 1 mg per kg that we give. Okay.